Friends, let us see how I managed this hard cataract. See the appearance of the cataract. It's very hard. It's a hard nut. And the pupil is not well dilated and it is going to shut down during emulsification of the pieces. However, I am not going to use a pupil expansion device. In this case, I am going to try without pupil expansion device because the pupil appears okay. The size is about 5 millimeter at this time. The main incision has been made. This is a side port on the left side of the main incision. The incisions include some capillaries. When the capillaries are included in the wounds, healing is much better. And now this is a bit of phenocane, and here goes an air bubble. Underneath this air bubble, trypan blue dye is applied over the anterior capsule. And now I use some adrenaline, but use of phenocane, which contains tropicamide, phenylephrine and lignocaine, as well as adrenaline, didn't cause any significant dilatation of the pupil. It was same as before. And now I am going to do Capsulorhexis using a Utrita forceps, making a puncture at the center. Go to left side, hold on side, and along the border I turn this capsular tag all around, and it becomes an adequate size trexis of about 5 millimeter. And now hydrodissection is done. Very little amount of fluid is injected at multiple points. I have injected this fluid in 2 points. In this case, SPMC is applied in the anterior chamber. Now I am going to take 2 hooks and bimanually rotate the nucleus, and it rotates nicely. And now little bit of enlargement of the main wound to about 3 millimeter. In hard cataracts, my goal nowadays is to allow some leakage of fluid through the main wounds so that the wound remains cool and wound burn can be prevented. But the most important point in preventing wound burn is controlling the foot switch and use of intermittent ultrasound. See, the exposed part of the tip is about 1 millimeter. I'm going to enlarge this. It is enlarged, and let us see how much is the exposed part. This is the exposed part, and it is about how much? It is 1.75 millimeter. So the exposed part of the phaco needle on the front side is on the longer side is 1.7 millimeter. On the beveled side it has not been measured. And now the handpiece goes, the phaco needle goes in, and some superficial cortical lens matter is removed. And now my plan is to turn the handpiece and use my submarine chop technique to divide the nucleus. The tip is buried vertically down first, just in front of the main wound, and then it goes horizontally through the substance of the nucleus as the submarine moves underwater. And by multi-level chopping, gradually I go down with my small chopper, Mohanta's chopper, which is just a modified Sinski hook, and I sculpt on ties to go to deeper level, turn 180 degree and divide the 2 heminuclei completely. Yes, I have got complete 2 heminuclei, completely divided, completely separated 2 heminuclei. Each heminucleus is then subdivided. The hold should be very nice, and hold should be at a deeper plane. If you hold it at superficial plane, the hold may not be good and your chop you may not succeed in chopping. And see the hard endonucleus. It is emulsified first, and now I tilt each nuclear fragment, go under the apex and pull it centrally and emulsify when it is at the center. The tip is at the center of the pupil when I am applying ultrasonic energy. The ultrasound is in continuous mode. If you can't control the ultrasound in continuous mode, you can use pulse mode. But I can control in continuous mode. I use ultrasonic energy intermittently and I give rest to the handpiece at regular intervals. This is just because in my hands in continuous mode the surgery becomes a bit faster, but it is always better to be safer, not faster. So if you find that in your hands you are using the pulse mode works better in your hands and it's safer for the patient, please use the pulse mode. This is the last piece of the nucleus. At this time we have to be very cautious. I decrease the vacuum and flow rate at this time. At this time the vacuum is 400, flow rate is 40. Earlier it was 480 and 48. At this time I detach the epinucleus and use it as a contact lens to protect the PC, and the tip is placed just 1 or 2 millimeter away from the center of the anterior chamber towards the main wound to prevent catching of the posterior capsule, and it is done. So we have managed the nucleus nicely. This is a piece of epinucleus. It is also removed, and now a little bit of cortex is there. And nowadays I always try to remove some cortex by the handpiece itself. I'm going to develop this skill for the last maybe 1 year or 6 months at least, and the cortex is almost clear. And now visco is injected. Little bit of lens fibers are there here and there. I'm going to remove that. Yes, some cortex is here. It's covered by the iris. Sweep and catch. This is the beauty of Simcoe cannula. You can just guess, sweep and catch. When you sweep, you keep the vacuum on with your hands, and cleaning of cortex is very nice now. Friends, this is a totally unedited surgery and you have not missed anything. Totally unedited at real speed. That's why it is taking longer time. It is taking about 10 minutes 20 seconds time. This is a single piece monofocal lens. See, my patients are from villages. My setup is at a rural area, so my patients can't afford most of the time the premium lenses, and these patients, those who are waiting for a long time and making the cataract so hard, they are really poor. But we take all precautions to preserve the tissue. We take utmost precaution to cause least injury to the corneal endothelium, and we prevent wound burn and try to do a very nice work. This is closure of this side port, and now see the main wound is clean. There is no wound burn, and it will not require hydration of corneal stroma at the main wound because it has been constructed in a triplanar way. And placing the lens properly. Yes, it is done. The eyeball is firm, there is no leakage from the wound, and the case is concluded. Thank you very much for your attention. Hope this video will help you in developing your surgical skills. Be a great surgeon and serve your patients, serve the mankind with utmost care, empathy and great surgical competence.